Hello, happy Teach Me Tuesday. Happy first Tuesday of December. Welcome to the busiest month for many of us, I think. Thank you for joining me. My name is Lisa. I'm an experienced NICU nurse and a NICU nurse educator here to give you another topic broken down for NICU nurses. And this week we are talking about the NRP 9th edition changes. One of my favorite things, actually. I love NRP. I've been an NRP instructor since, I'm trying to think. I always think about, like when I had my kids for dating, that helps me. About the same time I got my master's, so around 2016 maybe, so almost 10 years. I've been through the change of going from the 7th edition to the 8th edition, and now the 8th edition to the 9th edition. If you have been following me on social media or you get my newsletter came out yesterday. It comes out the first Monday of the month, every month. No matter what, not like the first day of the month, but the first Monday. So if you are not getting that and you want it, send me an email, go to my website. But there and on social media, here on YouTube and on all of the other places, I have been talking about our webinar that we are having on Friday. So this Friday, December 5th at 4 p.m. Eastern, we are doing a webinar all about NRP. We're going to go through these changes more in depth. We are going to do scenarios where we are applying these changes and really talking them through. So again, you can find that on my website. Leave a message here. I will comment back to you. You can send me an email. My email is lisa@niculearningnest.com. So you can send me an email if you're interested in the webinar or find it on my website, which is just niculearningnest.com. Anyway, let's dive into some of these changes. So I think it's so fascinating. I have done my instructor update. I've done the webinars for NRP 9th edition, kind of to prepare myself for this change as an instructor, but also for this, and listened to quite a few podcasts about it. Even a few months ago, there was a podcast with Amanda was on there, and they were talking about the science behind this and how kind of immediately when one edition comes out, they are starting to prepare for the next edition. And on average, they're coming out about every 5 years. They do an extensive literature review where they're really looking at this. It's an international committee. They're really thinking, is there new evidence to change anything we're doing? And I appreciate that about this whole process. And so what the 9th edition does is it's kind of constantly building on itself to say like, hey, we've got some great things, but how can we make it even better? So we are going to talk about the algorithm changes. We're going to talk about specific changes. And again, we are going to go more in depth and apply these to scenarios in the webinar on Friday. So I hope you can join us. At first glance, you can see here that there are some changes to the algorithm. I don't think that any of them are shocking. I think when we went from suctioning for meconium to not suctioning for meconium, that felt shocking. I think when we really started talking about putting EKG leads on during resuscitation, that felt shocking. These feel more of like a cleanup to kind of almost align with what people are typically doing. So initiate cord management plan is part of that first minute. Routine suction is removed. I could say that that's probably a bigger one of them. Really, we just suction if there's an obstruction and the baby needs some ventilation. So that makes sense to me. Vigorous term infant should go straight skin to skin. Amen. You know how I feel about skin to skin. For cyanosis with labored breathing and all of that, we need to do early CPAP. If your heart rate is less than 60, they actually call out the need to look for pneumothorax, which we've been talking about this last week with our chest tubes. And heart rate decision points are unchanged, right? But it's just clearer. So here's a picture of it. This is credited to the American Academy of Pediatrics and the American Heart Association. This is not, was not on our Instagram and TikTok slides because it's really busy and I want you to be able to pause and kind of look at it. But again, if we pause and kind of look at the front up here, we still have our team debriefing, our equipment check. Ideally, we're doing those things, right? We know that doesn't happen every time because maybe we're running, right? Or the baby's already been born. So like these are obviously the great plans if we can. We have our cord management plan, which we're going to talk about next. We have the same 3 questions: gestation, tone, breathing, or crying. Once we know those 3 things, we can kind of know what to do on the next steps. Those 3 questions are things we've already asked ourselves, right? That we've done that for NRP for a long time. Term, tone, breathing or crying, right? And if they are, they should be going to their parent, right? That's where they should be. If they're not, we're going to do some warm, we're going to do some dry. The provider might be doing that on the perineum, wherever the baby is born. If they're apneic or gasping, remember gasping is never considered an effective form of ventilation. Then we would move over, make sure we're on the warmer if we're not already, and begin to ventilate. And then watching our heart rates, etc. So as you get down here further into this algorithm, you do see this kind of split with the heart rate. Is the heart rate less than 100? No, but are they having labored breathing or some cyanosis? We're putting CPAP on. Again, I think that aligns more with what we were doing. So this 9th edition does feel kind of like a culmination of what was already happening. The other major thing I want you to see right here on this page is your target saturation. If you haven't read about anything that's going on with NRP yet, I want you to see that is starting at 2 minutes. Remember, it used to start at 1 minute. How well were we getting an oxygen rating at 1 minute? Right? If your baby's cyanotic, if they're apneic, if they've had any sort of difficult delivery, plus like getting it on there and all that. So this feels more realistic to when you're actually going to be getting a pickup. Now the numbers themselves have not changed. It's just when should we rely on it more. So that's also interesting. So let's kind of start from the top and talk about those differences. So what is our cord management plan? NRP now has a recommendation around milking of the cord. So first of all, delayed cord clamping is still recommended for 30 to 60 seconds for vigorous term and preterm infants. You can do that for 30 seconds. If the baby's not looking great, you can do it for a full minute, whatever seems to work. For non-vigorous term and late preterm infants that are 35 to 42 weeks, so non-vigorous, those are the 2 key words here I want you to really think about, is the term vigorous and the term non-vigorous. Non-vigorous, if you're 35 weeks, we're going to start considering to do some cord milking. Now, how many milks of the cord is it? How are we doing that? About 3. Also depends on what's going on with the baby. For 28 to 34 weekers, there's insufficient evidence, so they cannot make a recommendation. And for infants less than 28 weeks, it's actually not recommended because of IVH. So it really is important that we know if the baby's unknown gestation, they might be making a call in the moment of kind of, okay, this baby looks to be like at least 37 weeks. Let's go ahead and do cord milking. Again, I think this is part of those nuances that we're going to talk about today, where I think that it's making it a little bit tricky for us at the bedside. And let's talk about one more on our next one. So we get to that oxygen saturation and oxygen concentration. So we've already talked about how the table starts at 1 minute, but the percentages haven't changed. We now have an FiO2 guidance that's been clarified by gestational age. So again, you see that 35 week, which is the same for the cord milking. If you're greater than 35 weeks, we start at 21%. If you're 32 to 34, so kind of that late preterm infant, entering into that, like, idea of kind of you're probably bigger than 1,500 grams, 21 to 30%. If you're less than 32 weeks, it's greater than 30% or from 30 to 100%. What I think is nuanced about the 9th edition, and again, I'm not saying it's wrong, I'm saying it's nuanced and it's going to take us some adjusting, is there are many things divided by weeks now. And when you say either yes or no to something, it's easier to apply in every situation. But here, when you're talking about, okay, what oxygen saturation should I start with? Well, what if the baby's 31 and 6/7? Should we automatically start 30 to 100? Should we try 21? What if they're 34 and 6/7? Should we start at 21? And that is kind of why they're giving you some ranges. I just think it's, again, one of those things that we really need to think about. Again, probably aligning with more of what we were doing. I would say for most babies less than 32 weeks, we were probably starting at 30%, especially if we knew that they were depressed coming out. So something to think about as you begin to use this is this idea of what week is the baby and how is that going to align. Another change that's happening is PPV is now referred to as ventilation. That's probably going to be my personal hardest one to get over because I think PPV just like rolls off the tongue, positive pressure ventilation, but we're now just calling it ventilation. So our new ventilation rate is now 30 to 60 breaths per minute. 30 breaths is what we're doing during chest compression, so that kind of aligns there. I don't think, again, it's a huge difference to go from 40 to 60 to 30 to 60. So just a little different change there. Again, we're doing some PIP ranges based on gestation. So 25 is the acceptable recommended starting value, but if you're greater than 32 weeks, we're saying that it would be 25 to 30, and if you're less than 32 weeks, we're saying 20 to 25. To me, that means if you're still real tiny, we're probably not going to start at 25, so we have room to go. So thinking those 22, 23, 24 weekers are probably still going to get around a 20 to 22 PIP to start, where the 24 to 32 might be getting 22 to 25. I think this is one of those great opportunities back at the beginning of the algorithm where they said, like, did we have a team meeting? Is to say, okay, we know we're having a 25 weeker. What are we starting the oxygen at and what are we starting the PIP at? That's getting a shared mental model on what the next step should be. Another thing that has changed is with Mr. SOPA. We used to say to change every 15 seconds. Now we're saying 15 to 30, and they can be done in any order. So it used to be we kind of do the Mr. together, the SO together, and the PA together. Now we're saying, hey, if it looks like the baby needs to be suctioned, just do that first. If you're not seeing chest rise, you might want to change your pressure right away. So Mr. SOPA is still a great mnemonic to know, and I have it here for you. Go ahead and take a screenshot. I also have handouts on this that I'm going to put on my website, totally free and available. If you want to go grab just a quick handout with all these tables, it's going to be there for you. So again, NICUlearningnest.com if you want that. I think, again, were we probably doing Mr. SOPA in a variety of orders? Yes. So that's available for you there. Another change is that the LMA can be used as kind of your primary airway. Before it was like, oh shoot, we can't get anything. This is our last resort. Let's get this LMA in. LMAs are still very difficult in micro premature babies, so this is primarily going to be for your late term and term infants. It is useful when mask ventilation is ineffective, intubation attempts are delayed, and again, it's usually for those term or near term infants. Another change is that the ET tube sizing chart is more based on weight, less on weeks now. Both kind of fit in there. And we've also kind of got a little more nuanced with our weight here. So less than 800 grams, we're recommending a 2.5. But now they have put in there that we should consider a 2.0 for those smallest babies. If you're 800 to 1,200 grams or less than 1,200 in general, we're getting a 2.5. 1,201 to 2,200, a 3.0, and greater than 2,200, a 3.5. Again, do we always have a birth weight prior to initiating intubation? No. So that's why I think that this is a little bit tricky, is you're kind of doing a visual representation, or you can use those weeks, right? We've got 22 to 25, 26 to 28, 29 to 34, and greater than 34. So this chart, this whole chart here, again, is going to be on that handout that I'm going to put on my website. It's just going to have charts. So if you want it for a quick reference, print it off and download it. We've also said that they have changed how they are going to align the ET tube. So instead of saying it's at the lip, it's now at the gum, the upper maxillary gum at midline. So that just means your, upper gum on the baby. So that's where I've always been told you count anyway, because the gum doesn't move, the lips do, and the lips can move easily depending on how you've taped it. So that, again, is going to align a little bit more with what we're used to seeing. I don't think this is a huge change. I think the nuance is going to lie around kind of those 1,200 gram babies and those 2,200 gram babies. Most providers, in my experience, as you know, and I remind you every week, I am a NICU nurse and a NICU nurse educator. I've never intubated a real baby. I've intubated a lot of simulated babies, mannequins. But the provider's pretty good at looking, knowing, and that's why we usually have 2 tubes ready. So if you're taking, at a delivery for a 26 weeker, you may have a 2.5 and a 2.0 ready. You may have a 2.5 and a 3.0 ready. If you're at a 28 weeker, you might have both of those ready to go, depending on what the provider is saying. So in regards to kind of the overall major changes that are happening, those are the big ones. The other big thing is that there's a new chapter. I've read the chapter. I have access to the book. I find it very interesting, and I cannot wait to hear from all of you what your center decides to do. I am interested to know, are you already all PALS certified? I have never taken PALS. I've never worked anywhere where the NICU nurses took PALS. I have worked somewhere where we had babies up until a year of age, and we had a plan for them that once they were greater than 52 weeks, like another plan that we aligned with the PICU on. This required a lot of collaboration to create the plan and then simulations to carry it out of kind of how we would help the baby. In general, if you are in the NICU up until you're kind of in that BPD stage, respiratory is our primary problem, so NRP still works well. They do not have an official recommendation to say, this is exactly when we think you should switch to PALS. So if we think that the etiology is something like arrhythmia, shock, metabolic issues, persistent cardiac etiology, that's going to get us more into those. And then these guidances that they have here, I think, are also really important of kind of what the next steps would be. Do I think that there should be a PALS provider? Yes. Like our transport team had PALS, some of our doctors did, and then we had a PICU that had PALS that could come down at any time and help us. So I think having access to that is super important. Do I think every NICU nurse should have PALS? No, not in my opinion. I also think it depends on where you work. I have a friend that works at a children's hospital that does absolutely no deliveries, and most of their babies transfer in at about a month. They only have PALS. That makes sense to me. They're keeping kind of these chronic babies that are probably in the NICU for more of these variety of reasons. And so that kind of makes more sense to me than having, at a delivery hospital where you're primarily seeing micro premature babies, you have PALS. So that's kind of where I would stand on that. And not that any of you asked my opinion, but just in case you were thinking, what's her opinion? That would be it. So let's get our top at-a-glance updates. Cord management has non-vigorous criteria for milking. Remember the difference between a vigorous and a non-vigorous infant. The SpO2 targets begin at 2 minutes. FiO2 is now guided by gestational age. Ventilation rate, again, notice we didn't say PPV, we're saying ventilation is now 30 to 60. The PIP is based on gestational age. Mr. SOPA is 15 to 30 seconds and can go in any order. LMA may be used as a primary airway, and the ET tube sizes and depth have been updated. We're going to go through all of this in the webinar on Friday, and we're going to apply it to scenarios and kind of what would you do, what would you set, how would this be. It's going to be interactive, so I really hope you can join us. If you have any questions about it, again, look on the website or send me an email. But I think that this has been a great overview. I think what the 9th edition has done, especially with the addition of what to do in the NICU, has been really great. I think that there are some things that are very aligned with probably what we were already doing, and some things that are going to be a little bit more nuanced and maybe require more cards at the bedside. So I know most of us use that SpO2 reference card that NRP created, or you have something similar, but now will we need something to kind of be like, okay, starting FiO2 or ET tube size, starting PIP type of thing, maybe just by gestational age, to see like, okay, if you're 26 weeks, we're probably going to start at 30% or more. You're probably going to need a 2.5, and our PIP's probably going to be recommended 25, but anywhere between 20 and 25, right? So I have all on the line there. That's all going to come kind of together. I think that this is very scientific. I'm into the evidence review that they do. I loved listening to Amanda from Amanda's NICU Ed on the podcast that was on the incubator about this, or on NAN. It was on NAN about this. And I think that there are just some really great opportunities for us to implement this in our unit. So everyone's supposed to start teaching this by January with full implementation by June. If you're on a 2-year cycle like the rest of us, maybe you just took NRP, so you're not actually going to get this in a class for 2 years. So I hope that this helps you and gives you an opportunity to dive deeper. And if you want more, please join us for the webinar. And if you're watching this after the webinar is available on record. So you can still register for it and get the recording. And I hope you have a great day, a great Tuesday. Welcome to December. May the madness not overwhelm you.